Dear friend, dear patient, and dear colleague, good afternoon. My name is Marc Possover. Once again, I'm a gynecologist and the founder of the Neuropelveology. I'm located in Zurich. And today I want to have the next lecture on a very, very important topic, the pelvic neuropathy by vascular entrapment. That is a very, very important topic in neuropelveology because vascular entrapment is probably the most frequent cause for chronic pelvic neuropathic pain. So let's start directly. This condition, the pelvic neuropathy by vascular entrapment mean the irritation of pelvic nerve by large or atypical vessel is a very, very new condition, not really known by gynecologists and not known as well by radiologists. I discovered this pathology, I discovered this condition and mentioned about the vascular entrapment of the sacral plexus in the scientific literature first 2011. At that time, I saw a lot of endometriosis of the sciatic nerve, and sometimes I performed a laparoscopy and discovered that during the procedure, I didn't find an endometriosis on the sciatic nerve, but I found atypical vessel, mean vessel crossing over instead crossing below the sciatic nerve, or very, very enlarged vessel like you see on this picture, what we call an atypical gluteal vein. This vein normally would have to be below the sciatic nerve. In this patient, this vein is above the sciatic nerve, compressing that way the nerve between the bone and the vein. And this vein is very large, much too large for the superior gluteal vein. And at that time, I discovered that the patient with such kind of vascular entrapment had more or less the same kind of pain and this neurological disorder as patient affected by endometriosis, but without what we call neurogenic disorders. That means vascular entrapment induce an irritation of the nerve, not a destruction of the nerve. So, and the kind of pain the patient will report always the same in all pelvic neuropathic pain. The patient will report about burning, shooting, tingling, electrical shock, stabbing sensation, usually located in the lower back or in the buttock, with radiation down to the dorsal aspect of the thigh, down to the foot, to the third, and to the genital and what we call pudendal area, mean genital, perineal, and perianal area, with some issue with the bladder in the rectum, because vascular entrapment don't destroy the nerve, but induce an irritation, mean an overactivity of the pelvic nerve. The bladder and the rectum will present an overactivity called hypersensitivity, and that means patient will have to go very often on the toilet towards the bladder, will develop imperiosity, and exactly the same with the intestine, with the bowel. Patient will have, usually we said, colon irritabilis, but in fact the patient have not an overactivity of the rectum or an overactivity of the bladder muscle, but an overactivity of the nerve of the bladder or the nerve of the rectum, and that is exactly what we call an hypersensitivity. And of course, after several months or years of pelvic neuropathic pain, this will have a psychological impact on the patient with, at the end of the story, the fully isolation, the private isolation, social isolation, no work anymore, and sometimes even self-harm and even suicide. So, the definition of a vascular entrapment means that you have too big and large vessels, varicose vein that compress the nerve, or that you have aberrant blood vessels. That means the vessel are in the diameter normal, but they are compressing the nerve. And for vein to be able to compress a nerve, it's not just to have a nerve and a vein, you have to find this constellation in the narrow space. That means there are three different kind of vascular entrapment in the pelvis. The first and probably the most frequent is an irritation of the sciatic nerve within the pelvic cavity, and just before the sciatic nerve will pass through the what we call foramen, greater sciatic foramen, so will leave the pelvic and go to the buttock. So this first location is really the most frequent and induce usually sciatic pain. The second location is an irritation of the pudendal nerve, just where the pudendal nerve is leaving the pelvis as well, what we call the less sciatic foramen. At that location, normally anatomically, we have one arteria, two veins, and the nerves. And when this space, this foramen is too close, too narrow, then patient may develop an irritation of the nerve, and then the patient will develop a pudendal neuralgia, but not an Alcock canal syndrome, because the pudendal neuralgia, the irritation of the pudendal nerve, is not below the pelvic floor as in Alcock canal, but above the pelvic floor. So if you perform a block of the pudendal nerve at the level of the Alcock canal, the patient will not will not experience any improvement in pain. That will prove that the irritation is above. And usually, when a patient develops a vascular entrapment, there is also some irritation of part of the sciatic nerve, mainly the lower part, that is correspond to the S2. That means it's more or less a combination of pudendal pain and sciatic pain, low back pain, and gluteal pain. And when the patient has an irritation, the first location of the sacral nerve root, S3, S4, then the patient will combine definitively sciatic pain, low back pain, gluteal pain with pudendal pain, mean vulvar pain, perineal pain, and perianal pain. And because of the irritation of what we call the pelvic splanchnic nerve, an hypersensitivity of the bladder and on the rectum, patient will have to go very often on the toilet, even when the bladder is empty, will develop imperiosity, some pain in the area of the bladder, mean above the pubic bone. So this vascular entrapment, once again, is really the most frequent cause, by far the most frequent cause for chronic pelvic neuropathic pain. So then, when there is an issue with the nerve, there is always a question if the lesion is neurogenic or non-neurogenic. I remember you, neurogenic means it's an issue that will induce damage to the nerve. So neurogenic cause are surgical damage, endometriosis, tumor, schwannoma. On the other side, we have non-neurogenic. That means the condition will just induce an irritation of the nerve, but no impairment of the function of the nerve. And that is exactly the situation in vascular entrapment. Usually, there is no neurologic disorder, no weakness in the leg, no numbness, except when arteria are compressing the nerve. So, to get or better over the last 2-3 years, I was always thinking why some patients may develop a pelvic neuropathic pain by vascular entrapment. Because all of us, we have nerve in the pelvis, all of us, we have vessels, sometimes enlarged vessel in the pelvis, but not all of us are developing such a kind of chronic pelvic neuropathic pain. So day after day, by asking my patient, by making the patient history, I found that quite a lot of patients report about any autoimmune disease. And I just sent a paper the last few weeks for publication, a paper where I make the correlation between autoimmune disease and pelvic neuropathic pain. And we found in this paper, or report in this paper, that more or less 30% of the patients coming in our department with a pelvic neuropathic pain are affected at the same time by an autoimmune disease. And by far the most frequent autoimmune disease is the Ehlers-Danlos syndrome. So when patients and an over elasticity are able to bring the tongue to here, that is very, very strong sign, for example, for an Ehlers-Danlos syndrome. Or when you do that, you extend your arm and the angle is going down, that is very typical for an Ehlers-Danlos, or at least an hypermobility spectrum disorder. Now there are some other connective tissue anomaly, the Marfan syndrome or Marfanoid syndrome, patient, very, very tall patient with a big mandible, and the Raynaud syndrome, typical woman, more women than men, when they bring the hand in water, in cold water, the finger will become white. And then what we discover as well is that a lot of patients reported about Hashimoto thyroiditis, arthritis, lupus. So all these connective and autoimmune disease induce enlarged or atypical vessel in the pelvis. For example, Ehlers-Danlos, when you have an hyperlaxity of the tissue, for the same pressure within a vein, the vein will become bigger as a normal patient. All these diseases seem to be linked with vascular pathology, mean atypical vessel, not just in the pelvis. It could be at the level of the aorta. For example, Marfan syndrome, this patient with an increased risk to develop an aneurysma of the aorta. A lot of these patients also may develop some aneurysma in the brain, but fact is, today, since we know that autoimmune disease are linked to pelvic neuropathic, in my consultation over the last 6 months, I suppose that more or less 70-80% of the patients coming with chronic pelvic pain, and we don't found a cause for that. Once I ask for an autoimmune disease, a connective tissue disease, or an Ehlers-Danlos syndrome, the answer is positive. The second risk to develop atypical or enlarged vessel in the pelvis is one, the May-Thurner syndrome, which corresponds to a stenosis of the left common iliac vein. So when the left common iliac vein, where the full blood from the left leg and left pelvis in passes through, is too narrow, then you will have an accumulation of blood in the pelvis below the stenosis. Same with the Nutcracker syndrome, that is a stenosis of the renal vein on the left. And for the same reason, the patient will have an increased venous blood pressure on the left side. So it's quite easy for a gynecology to suspect such kind of May-Thurner syndrome or Nutcracker syndrome. When you gynecologist is doing a sonography, a vaginal ultrasound to check the uterus and the ovarian, you have just to push the button Doppler flow to see the vessel. And here on the picture, here on the left, you see a uterus, and you see that on the left here, there is plenty of color. So this patient have enlarged parauterine vessel on the left comparing to the right. And when a gynecologist sees that, first, you have to send you to a radiologist to let perform an angio-MRI to check if you have May-Thurner syndrome or Nutcracker syndrome. And secondly, if you're suffering from low abdominal pain, please don't take any hormonal treatment, oral contraceptive, because May-Thurner syndrome and Nutcracker syndrome increase the risk from pelvic thrombosis and lung embolism. Then there are further risk for pelvic thrombosis, clotting disorder with first factor V deficiency, factor V Leiden mutation, protein C, protein S, and antithrombin 3 deficiency. Of course, pregnancy and delivery are risk to develop pelvic thrombosis simply because the head of the baby, when the head is pressing for a long time on pelvic vein, it can increase the pelvic thrombosis. Malignancy, tumor, can induce pelvic thrombosis. Once again, oral contraceptive, that is very, very important. You have not to forget that the combination of estrogen, progesterone, really increase significantly the risk of thrombosis, even more when you're smoking, yes. And third, thalassemia. Thalassemia in our country, in Switzerland, I always ask my patient if they are coming from Middle East, from Turkey, because thalassemia is a very, very common disease in Middle East, and thalassemia increase the risk of pelvic thrombosis. And of course, when you have a pelvic thrombosis, the vein is closed because of the thrombosis, and then before you have an accumulation of blood, and the vein will get bigger. Pelvic thrombosis you can suspect by the vaginal examination when your gynecologist feels some small stone at the level of the vagina. That is what we call phlebolith. Phlebolith are typical for calcification of past pelvic thrombosis. So now how to make the diagnosis? So today in gynecology, if we suspect something, if we are not sure, we always send the patient to the MRI. And MRI will see if you have a tumor, if you have endometriosis, if you have myoma. But now, magnetic resonance imaging in vascular entrapment have really significant limitation. Why? For a simple thing, radiologists know the phenomenon of irritation of nerve by vascular entrapment. That is a well-known situation for the trigeminous pathology. But in the pelvis, that vein may induce an irritation of pelvic somatic nerve. That is a condition that is definitely not known by radiologists. They are able to see enlarged vessels, but they will not recognize that as a pathology. They will be able to see the exact location of the vein, but to see if the vein is running below or behind a vein, that will be very difficult for the radiologist. So normally in my center, when I get an angio-MRI from colleague not trained in vascular entrapment, usually the MRI is normal. So in pelvic neuropathic with normal MRI, that don't exclude a vascular entrapment. But the MRI is very important to exclude another pathology, because you can suffer from an endometriosis sciatic nerve, from a schwannoma, from a teratoma. Maybe we'll find some clip or some fibrotic tissue on the nerve. So you have to exclude another pathology. The key for the diagnosis, for the clinical diagnosis of a vascular entrapment, is the vaginal sonography, or in men, the rectal sonography. Because you can go with your sound inside the vagina, you can go in direction of the trigger point, because during the vaginal examination, you will put your finger on the different nerve, on the different root, on the pudendal nerve to see where is the main pain. And then you will bring the head of your vaginal probe to this point, and then you will put on the bottom Doppler flow. And then when you see that what we call a reverse flow, that the blood flow of the vein is going down and up and down, that is what we call a reverse flow. That is typical for pelvic varicose vein. In Ehlers-Danlos, because the vein wall have no elasticity, usually we found a flat curve. And of course, when the vein, the pelvic side wall vein, are more than 6 millimeters in diameter, that is exactly the definition of a pelvic varicose vein. That don't mean that the vein you will see in sonography on the veins that compress or irritate the nerve, but it's a very strong argument to say probably you have vascular entrapment. So the key for the vascular entrapment is the patient history. And because we are talking from vein, Everything that will increase the blood pressure in the vein will increase the pain. So, sitting for a while, standing for a while, coughing, holding something heavy, all these situations, including the men's bleeding, will increase the pain. While all situations that decrease the blood pressure will decrease the pain, first of all, lying down. And most of the patients with pelvic neuropathy by vascular entrapment will report that over the days, the pain is getting worse, worse, worse. They are going in the bed, and in the morning, they wake up with more or less no pain. They are staying up, and once they are in the vertical position, the blood is going down again in the pelvis and in the legs, and the blood pressure increase again, and the pain reoccur and increase over the day. So the treatment in neuropelveology, we are not treating symptom, we are treating cause of the pain. And when you have a vascular entrapment, like you see on this picture on the left, that is a typical atypical superior gluteal vein, enlarged superior gluteal vein that compress the sciatic nerve and the sacral plexus. So this patient definitively had to have to go very often on the toilet, had lower back pain, about gluteal pain, buttock pain, eventually down to the legs, and in any case, vulvar pain, what we call vulvodynia or pudental pain. And the treatment is to by laparoscopy, has to be done by laparoscopy because you need a magnification of the structure. You need a kind of microscope close to the nerve and the vein. By open surgery, you have no chance. Robotic maybe, but the arm of the robotic take a lot of place. And here we are very, very deep. And I am doing the laparoscopy because I want to have the feeling. And this feeling is very, very important because you have to detach and to separate the vein from the nerve. And once you got this situation, then you have to use coagulation. You burn the vein and you have to cut the vein. If you just close the vein, probably over months or years, the patient will develop a recurrence. You have to cut the vein, only the vein compressing, irritating the nerve. Is no need to cut all the nerve in the pelvis. You have plenty of other veins in the pelvis, so to cut the gluteal vein or the vein compressing the nerve will not change anything in your pelvis. So the aim to cut the vein is to release the nerve. So you see on the left, it was before with a huge vein compressing the nerve. And after you see here, this black area is the area of coagulation of the vein. We cut the vein and release the nerve. And with that, if you have made the right diagnosis, mean you know exactly where you have to find the vascular entrapment. You cannot go by laparoscopy and open everything just to check. Could be the vascular entrapment here on the left, here on the right. No, you have to know exactly where you have to look. And usually, when you found on large vessels on one side, the patient have more or less 80% risk to have the same kind of vascular anomaly on the right side. So in vascular entrapment, when patient is coming even with pain just on one side, for example, the left, once we confirm the diagnosis of vascular entrapment on the left, then we are going to the right and we are exposing the nerve as well. And if we found aberrant, atypical, or enlarged vessel on the right side, then we'll coagulate and cut all the vein in touch or in close relationship to the nerve. Now the results, the overall results are around 70% of pain reduction, more than 50%. Nobody, no any surgeon, no any pain doctor will be able to tell you, I'm the best, I'm the greatest, I will do something and then you will have no pain. No, pain is very abstract, it's very difficult to deal with. And all patients affected by pelvic neuropathic pain will have pain memory, what we call central sensitization. So what we can offer the patient is a pain reduction more than 50%. Sometimes it's more. Sometimes patients have no pain anymore. But one is sure, The pain will not disappear overnight after the surgery. Usually, patient is coming with a lot of pain. You do your procedure. Because you're close to the nerve, you will induce what we call a neuropraxy. So the nerve will get sleepy, exactly the same phenomenon as of when you're sleeping on your arm overnight. You wake up in the morning and your finger, your hand is sleepy, is numb. It's exactly the same phenomenon. So after the laparoscopic operation on decompression, the day after, most of the patient will mention some not really numbness, but a reduction of the skin feeling and some weakness, but there is no risk to become paraplegic because the sciatic nerve is just in charge of the buttock and the ankle. So no risk to end up in a wheelchair. So the pain will decrease, and then after a few days or few weeks, the pain will increase again, and the pain will increase maybe the same levels as before the surgery, and it will take 6 months to 1 year until the pain will start to decrease. And the more central sensitization, the longer it will take until the pain will decrease. So after the procedure, we support the patient. In our department, we have report from the patient every 3 months, and we follow the patient for 1 year. And we give, after the procedure, the patient a combination between CBD drops and Lyrica to try to control the pain level and to try to reduce the pain memory. And of course, we advise the patient to try to recover as soon as possible a normal life. Normal life mean that the patient has not to spend all her day and night in front of the computer to analyze everything and to try to understand everything. That is not good. The patient will not forget the pain, and that the whole process will take much, much longer. Now, if you are affected by vascular entrapment, there are two things you have to avoid. One is embolization. I know that some radiologists are becoming aware on this pelvic neuropathy by vascular entrapment and want to bring to perform embolization. Once, if they are doing the embolization at the level of the iliac internal vein, that means more distally, they will close the vein and the blood pressure below will increase. The pain will increase. It's exactly the same as if patient undergo an hysterectomy, a removal of the uterus in vascular entrapment. Usually the pain will increase because you have more blood in the pelvis, the vein will become bigger and will induce even more irritation of the nerve. By the way, it makes no sense to try tense therapy in vascular entrapment because once the nerve is irritated, if you bring electricity on it, you will even increase the irritation of the nerve. It will make your pain worse. So, second, you see on this picture on the top, here a radiologist tried to put a stent inside the superior gluteal vein. It was a dilated and atypical superior gluteal vein crossing over the sciatic nerve just below. And you see here this piece of metal were directly pressing on the sciatic nerve. So the embolization made the situation even worse. The patient had a terrible pain, and believe me, to remove a vein with piece of metal inside is not easy. So avoid embolization. The second is a message not for radiologists, but for gynecologists. If one of you try to do a laparoscopic exploration by vascular entrapment, please don't use suture or clip or hemoclip. Here you see that is a patient. A colleague tried previously to perform an exploration and obviously he got a bleeding and controls the bleeding with a clip. After after the procedure, patient developed worst ever pain. And why? Because the clip were in direct touch to the sciatic nerve. So we had to perform a laparoscopy. It was really a very difficult procedure. We had to release all the nerve out of the retroperitoneal fibrotic tissue. And Then we had even to open a little bit the layer of the sciatic nerve and to take out the clip out of the sciatic nerve. So please, no clip. So in conclusion, vascular entrapment is definitively the most frequent cause for pelvic neuropathy. You have to think about this pathology when you develop burning pain in the lower back, buttock, genital area, eventual in the thigh, when this pain increase over the day, decrease over the night, increase during main bleeding, decrease after the main bleeding. And the laparoscopic, the treatment of choice is the laparoscopic decompression, which is not a gynecological procedure, that is a purely vascular procedure performed by laparoscopy. For me, it's quite easy to do that. Although easy, I'm more trained to do that because before becoming a gynecologist, I was a cardiovascular surgeon. And that is a message for all gynecologists who try to start with this procedure. First, the diagnosis is a cornerstone of effective medical care. So the results of your procedure will definitively directly depend from your diagnosis. There is no way to go simply by suspicion to go by laparoscopy in the pelvis and just to take a look and to see if I'm right and where on the left, on the right, on the top, on the bottom. No, you need a clear diagnosis before you go with a patient in the OR. And then you have to have a perfect knowledge on the pelvic vascular anatomy, and you have to have some knowledge in vascular surgery. Once again, laparoscopic exploration decompression for vascular entrapment is not a gynecological procedure. It's a vascular procedure performed by laparoscopy, and is not that difficult procedure if you're on gentle, if you're a vascular surgeon, when you know exactly what you have to do. But still, it's a very dangerous procedure because we are on the pelvic side wall. You have sometimes very, very big enlarged vein, and the main risk is to get a very, very huge bleeding, life-threatening bleeding. And in this situation, once again, the surgeon has to be trained in vascular surgery, first to avoid the bleeding, second, in case of bleeding, to be able to control the bleeding. And I thank you very much for your attention, and see you the next time for another lecture on neuropelveology. You remember, I believe in education of the patient. It's my duty to educate, do not just collect my patient as well. And keep healthy. See you next time. Bye bye. Good afternoon.